So yeah, my name's Gabriel Doctor. I am uh, I guess what's called an internal medical, core medical trainee in the NHS in my second year. That means I've done 4 years of medicine since graduating medical school. Um, Before that, I went to medical school when I was 26. Before that, I worked in politics for a little while, and I did an English degree before that. So I've come to medicine a little bit late, and perhaps it's given me a bit of a different perspective to some other of my colleagues who are at the same same stage as me, but maybe a little bit younger. Um, so yes, so I work in a what's called a district general hospital in the NHS. Essentially, that means it's not a central London or central teaching hospital. Although it's a good hospital. It's affiliated to some of the London teaching hospitals. It's a busy place. It's one of the places that's been awarded a lot of money by the government for redevelopment. So it's a kind of, I'm just setting the scene as it's like a busy area hospital just outside of London, and we've got a very busy A&E, very high throughput, and luckily we also have a very good respiratory team, and I'll talk about that a little bit more later. I am, just so you know about my skills and so on, so as I said, I'm in 4 years post qualifying. I am in a training pathway to become an internal medicine. So that means essentially I'll actually next year start training to become a nephrologist, a renal doctor, kidney doctor. And the training for that is basically I've done a bit of everything so far in terms of adult general medicine. I've done cardiology rotations, stroke rotations, elderly care, acute medicine, endocrinology, so on. So I'm like the workhorse of the hospital, and we're the people who fill the rotas and see people where they need to be seen and deal with, given a broad enough training generally to try and deal with anything that's not surgical or obstetric that's thrown at us. That's the goal. So I guess I should say what I'd like to talk about. Firstly, I'll say what I'm not going to talk about. So this is not really a forum. If you've got any pressing medical questions, this is not really a forum for that. Firstly, I don't think everyone else wants to see your rashes. And in any case, I am not in a position really to give specific medical advice. That I can, if there's general questions about the government's guidance for coronavirus, we can talk about the basics of that as well. And what I was thinking of telling you, which might be interesting, is what's happened in a hospital. Like I said, typical hospital just outside of London in the last 3 or 4 months. What's been going on? I can tell you a bit about specifically what I've been doing and how my job has changed. I can also tell you, for those who have a bit of a stomach for it, what this disease looks like in a hospital inpatient, and that may be something that some of you may not want to hear. So I won't do that without giving you a bit of warning. So I'll just start and tell you about the hospital quickly. I guess what I'll do is I'll talk for a few minutes and then leave for questions, or you can just start posting questions on the side. So in January, if anyone remembers back to then, the previous big news story in January was about some bombing Iran, and we all thought that war was going to break out in the Middle East. And then we also hearing about a virus that sort of started somewhere in China, and at the time many people thought that that's where it would remain. And even those who thought that it was a big deal, I guess, we heard about SARS before and MERS, these other infectious respiratory viruses, but they'd never quite made it pandemic. and I don't think anyone knew what that would be like. But then I would say we received an email in our hospital at some point in January from the chief executive saying, don't worry too much, we're monitoring the situation. That was the tenor of the email. And then there was kind of radio silence after that. And I'm sure there was lots of stuff going on in the background, but I think for me and many of my colleagues, the first time that it felt very real and imminent was when we heard what was happening in Italy, because there was a country that's not far away that has a health system that was understandable, that many of us have been to. Many of us had been to Lombardy. And then I would say actually there was a very influential Twitter message that went out in late January, early February, from a Lombardy physician, an ITU, talking about their experience. And that, I think, sent shivers down everybody's spines in the medical world. Certainly for those who, I'm sure, as I say, planning was going on already, but that was the moment where we saw pictures coming out of patients being treated in hospital corridors and people, there just not being capacity for ventilators and not being capacity at the front doors, and an understanding that this was now, that a Western health system, one that we could understand, was becoming completely overwhelmed. And not just, it's not the southern, it's not a poorer part of Europe, it's one of the wealthiest parts of Europe that was just being completely hammered by what was happening. And at that point, everything seemed to click into gear, certainly at my district general hospital. I can tell you my role in that as well, but suffice to say that was the start. And very quickly after that, I will tell you that the whole hospital was reorganized. And what was reorganized was how the A&E works, how all of us frontline medical dog's body junior doctors are working, how surgery is working, how outpatient clinics were working. Everything changed remarkably rapidly. And that's sort of where we still are now. Things are still very much changed. Though one of the interesting things is whether they're going to start moving a little bit back towards normal. So I'll tell you a bit more specifically about how things have changed, but I'll just tell you specifically then about me. I was asked, we organized a survey at some point in February, early March, in late March, in March. So looking for what skills I had in terms of intensive care. Now, I've not worked in intensive care, and it's not part of my general hospital dog's body training as such, but I had done what's called some HDU, high dependency unit, respiratory care. That's for people who are on not ventilation assistance, but not invasive ventilation. They don't have a breathing tube going down, but they have things like CPAP and BiPAP, which are commonly used tools to help people through respiratory diseases when they need it. And I'd also done quite a lot of, spent about 4 months working in a coronary care unit, CCU. That's like a place where you send patients who've had acute heart attacks or are having rhythm disturbances in their heart. They require a higher level of monitoring. And you also use some kind of funky drugs in those kinds of wards. And so I said, well, this is the experience that I've had. I haven't had ITU. And I got an email back about a week later saying, we want you. So what they wanted me and about 10 of my colleagues for was to become medical doctors, non-ICU doctors who are going to work in the intensive care unit to support the efforts there of the intensive care doctors. And so I have had a real whirlwind upskilling and introduction to life in intensive care. And it's fair to say it's intensive care as the intensivists have never known it. It is, it's hard to describe. It's very intense, and people are, I would say usually on an intensive care and of my hospital, which usually has 7 beds, they may have maybe one very, very sick patient, each day who they're worried about, and the others are kind of in a state of control. And here it would be 90% of the patients are very sick and teetering out of control. And that's the world that I've been thrown into over the last 3 or 4 weeks. So let me tell you a little bit more about how a hospital like mine is working. So I'll go back to that. So the junior doctors, so that's everyone from a foundation, which is a first year, up to a pre-registrar doctor, a registrar doctor. So anyone between a first year training and the consultant has essentially been thrown into a massive, what we call the pandemic rota. And this is now providing 24/7 cover across the hospital. But not just having a few doctors around overnight, there is almost an equal number of doctors at all hours of the day and night at the hospital. And this was done because the feeling was that there was going to be a wave, a tsunami of sick patients that was going to hit us. And we would be having ambulances queuing day and night. We would be admitting patients from the ED day and night. And we felt that it was going to be necessary to staff the hospital, to super staff the hospital at all hours, essentially. So the rota for most people is, it's a 9-hour shift that my colleagues are doing on this rota, 9 hours. The first shift is 7 till 4. The second shift is 3 till midnight. And the third shift is 11 p.m. till 8 a.m. And so you can see there's a little overlap there to allow time for handover of patients. And this is what and you do four or five of these shifts per day, sorry, in a row. So you do four shifts on that time period. Then your 5th shift is what's called a shadow shift. So if necessary, you're asked to come in. If not, then it's a day off. It's a day off. And then you have 4 days definitely off, and then you move on to the next time bracket. So you get quite good rest between these shifts. But on the other hand, as you can imagine, they can be quite tiring while people are in there. So that's how people are working now. Very different to our normal way of working. The consultants are also, they're not there until they're not there 24 hours a day, but they do start a bit earlier. They now start at 7 instead of sort of 9, and there are more consultants about, and they also work later. They're also on sort of different rotas. And it is now the hospital providing really a 24/7 service. Questions we can discuss later about whether it's necessary, whether it's just been worthwhile, and whether it will be done like this in the future. I myself am not working on this rota. ITU has stuck to a more traditional 12-hour pattern. So my shifts are 12 hours or 13 by the time handover and so on. It's a very, it's a rota pattern that could only be described by designed by a computer, because it's very confusing. I always have to double check when exactly I'm on or off. For example, I've just come off a period of nights. So over the last 2 weeks, I haven't worked any day shifts. I've just been doing night cover between 8 p.m. and 8 a.m. in the intensive care unit. I do 2 nights, and then I've got a few days off, and then I do 3 nights, and I've got a few days off, and then I do another 2, and then I've got a few days off. So it's really very, very, very confusing. I sleep when I can, and now I've got a few days off before going back to my days. So I'm now going to be back on a 12-hour day shifts coming up this week. As I said, the hospital was reorganized. At first, all elective surgery was closed, and there was still, obviously people are still coming with emergencies. But the surgeons, they stopped doing what we call elective surgery. Some of which it's a very it's elective only in the sense that it's not a super duper emergency. It means you can choose the time, daylight hours, that you're going to do the surgery. But obviously it includes all things like cancer operations, many many kinds of procedures that, orthopedic surgery, long-standing things. And this is obviously, these are serious problems that have essentially, the solution for which has been put on hold, or the treatment for which, such as this, has been put on hold for some time. All the surgeons joined onto this general pandemic rota as well. Although now it turned out that we didn't need quite so many people. So the surgeons are now doing their own work again, and the hospital is kind of beginning to, hopefully that's one aspect of things that's getting back to normality. So these funny shift patterns are unusual. You can imagine as well that there's a lot of anxiety. Another thing that's changed is we're doing all our work now in protective PPE. I'm sure you know there's a lot of concern and anxiety around PPE. So the different colleagues in different parts of the hospital will be wearing different kinds of PPE depending on which patients they're seeing and the certainty of contact. In order to prevent infection, the A&E has been divided into what's called a hot or a cold or clean and dirty, so COVID and non-COVID. And so, for example, in the ED, if you've got suspected symptoms, you'll go more or less straight into the hot area, and you'll be seen by a doctor who's wearing a full visor and a mask and a full overall, essentially, or essentially a surgical gown, double gloved. And the ED doctors will sort of do patches about 4 hours in the hot area, and then they will kind of swap out, because it's quite difficult to spend much more than that walking about, doing procedures, dealing with sick patients in this PPE. Arguably, it's also arguably the filters become a bit saturated at that point, and it may be that they're less effective for the masks at that point. Yeah, and then in terms of the patient, so you come to ED. If you were suspected coronavirus, at that point they would decide whether you were you would make an early decision about whether you thought this person would be intubatable. If the patient might be intubatable, not necessarily needing it at that point, but if things got worse, and then they would be moved to one set of wards. And if it was felt that regardless of their whether the disease is severe or not severe, but if it's felt that they would not benefit ultimately from being intubated, then they would be moved to a second set of wards. There's the same number of doctors, teams on both, but the doctors looking after the intubatable patients was basically the respiratory team, and the other patients would be in a kind of different bit of the hospital. And again, on one side, they might be more likely to have some of these other breathing techniques applied, the CPAP and the BiPAP and so on, which will kind of prevent a serious deterioration. That's a kind of patient pathway. And then, the majority of patients, like everywhere, will get better. Even of those who come to hospital, the majority get discharged. But once you're requiring, once it's serious enough to be requiring, once you're reaching the limits of self-ventilation or even supported ventilation with a CPAP or a BiPAP, these supported ventilations. Once you're moving towards intensive care, which means intubated ventilation, where you have to be sedated, have a tube put into your breathing tube into your trachea to ventilate your lungs. Unfortunately, at that point, your prognosis becomes quite poor. So one of the questions that's what's been asked up is here is how big is the ITU? So that size of the hospital has been expanded from 7 beds, like I said before, to 28 beds. So it's quadrupled in size. And in fact, what's happened is that we've taken over one of the old geriatrics wards. So one of the wards that was previously a place where essentially there were a lot of patients with confusion and urinary tract infections and things like that, has now been transformed really over the course of 3 or 4 days is all it took, into a intensive care unit with another 21 ventilators, with drug cocktails available, with all sorts of laryngoscopes and drips, and it's a heavy duty, fully functioning intensive care unit. And that is where I've been working mostly on this this new ITU, the overflow ITU. And we did at one point reach 27 patients at our hospital. We never, I think, had all 28 beds occupied. It's now, the numbers are now coming down. And in fact, they've combined the 2 intensive care. They've moved the original intensive care, all the coronavirus positive patients, onto our unit now. So I would say in total, there's probably about, from a peak of 27 intubated patients, there's probably now about 15 intubated patients intubated with coronavirus there. And luckily and happily, what this has meant is that they've opened up the main ITU again as a clean intensive care unit, which means they can start doing surgery again. You can start taking because you have to have a intensive care unit open for surgical complications, for post-surgery recovery and so on. And so it's a very important move that they've now got a place where they can say, right, we'll try and keep this with patients who don't have coronavirus, and that will allow more normal functioning again of the hospital. Yeah, so does anyone have any, I think I've probably given an overview there. There's a couple of questions that have come to me, unless anyone else is, Ellie, unless you want to kind of kick things off.
Gabe, so now over to the floor, to the crowd, to the floor for Q&A. Thanks.
So like I said, if you've got a question but Ellie can't see you, just pop it in the Zoom group chat. So I'll tell you 2 questions that have already been asked. So I think Hannah's asked key measures. Hannah, do you mean treatment measures? What are we sort of trying to do for these patients? So I can't see your face, but if you just, I guess that's a good question. So how do we try and treat coronavirus patients? Well, there is no treatment as such, right? We're in a state, I guess it's like, imagine that we're in 1915 or something, 1920, before the invention of penicillin, right? I think Alexander Fleming noticed the mold in 1922 or something like this. Anyway, in that world, pneumonia was a killer. It was a terrible disease. Once your lungs were infected, it was 50-50 about whether you would survive your bout of pneumonia. And I think that this is how coronavirus feels a little bit today. Not the statistics aren't as bad as that, but the point is that we're so used to having a world where we have treatments for things, staph aureus, you get a pneumonia and we just give you comoxiclav or clarithromycin. You know, these are drugs that cost pence to manufacture and to buy, and it's become second nature. And the drugs are, you know, the drugs are sort of safe enough that anyone we even suspected in, we dole these things out, and we don't have that for coronavirus. We don't have a medicine that treats it in that way. So there are a few things that will happen. So if you're requiring, so first, this is not a reason not to come to hospital for anyone who happens to have symptoms. If you're unable to cope at home, it is the right thing to do to come to hospital. What will happen to you is that you will immediately be given oxygen support. You'll be given either a nasal cannula, which are little prongs connected to the wall, or you'll have a blood test done called an arterial blood gas. And this basically looks at both you get a saturation probe on your finger that tells you that number somewhere. It should be above 94, about how your blood oxygen saturation is doing. And the arterial blood gas will tell us about your, in the blood itself, what the oxygen pressure is, what the partial pressure of oxygen, the partial pressure of carbon dioxide is in the blood. And these are the two kind of key metrics that will determine how much oxygen you require. For many people, what they just need is a bit of oxygenation support, just to tide them through until their lungs clear up, until the mucus can be cleared and so on from their lungs and the inflammation dies down. And this will be the course for many, many people. They'll either have nasal cannula, they may have a full oxygen mask, and some of them may require what's called a reservoir bag mask. That's the one where you've got, you know, the breathing tube and a bag there, and this ensures that with every breath you're taking, a very high proportion of oxygen comes into your lungs. One of the other things that so most people, everyone will get that basically. You'll also get probably you will get antibiotics depending on your blood test results, just to cover the possibility of a supra-added bacterial infection. That means that you've both got pneumonia, you've got coronavirus, and because your respiratory defense mechanisms are impaired, you'll get you may get a bacterial infection on top of the coronavirus infection. So you're probably going to get antibiotics. You'll ask to lie on your front as much as possible. This is called proning, and what this does is it alters your respiratory physiology in terms of the matching of oxygen supply and blood supply in your lungs. And basically, it allows in general, the bit of your lungs that's lower down has got a better blood supply, worse oxygenated. So when you lie on your front, it basically matches up a bit better your blood supply and your where the blood supply is good in your lungs and where the oxygen supply is good. And these are simple measures that do seem to prevent deterioration or hold people just at that level where they're requiring oxygen, but you don't need to take things further. If things are taken a bit further, then you'll need one of the things the technologies that's become is very well described, but is being used in a way that it's not been used before, is CPAP. That's continuous positive airway pressure. And what that does is it splints open your airways to allow gas transfer to happen. Even if your lungs are impaired and a bit messed up by this virus, it's going to allow some gas transfer to happen. And hopefully spare you the need for intubation. And then the other thing that we can do, which everyone is in my hospital is a big push, is to be enrolled in a clinical trial. So just because we don't have a known treatment, and I'm afraid that bleach is probably not a treatment, and detergents should not be tried at home. We don't have a known treatment for this, but a trial is one way of working out what does and doesn't work. So our hospital is part of the recovery trial. This is a very big UK trial. It's got a really novel enrollment approach. So usually to be a trials enroller involved in the trial, you have to do lots of training online. This has a super simple series of videos that you watch as a doctor, the nurses can watch as well. And then there's a very simple randomization tool, and it's actually a really great tool. So one thing we can do for every patient, which we're trying to do for every patient who comes into the hospital, is enroll them in the recovery trial. And that will randomize you to standard treatment, to steroids, hydroxychloroquine, which is one of the ones that's been talked about a lot, to a combination hepatitis drug called ritonavir, lopinavir, or to standard treatment, and also now to a final treatment that's used in rheumatological diseases, a sort of anti-inflammatory drug. So if you're enrolled into the trial, then you may get one of these treatments in addition to standard care. Now, we don't know if any of these are going to work, but that's why we're doing a trial, and it's the most useful thing in terms of treatment that we can offer for anyone at the moment. If you don't make it, if you're still struggling to breathe, then you'll be moved to the intensive care unit, and that's where I am now. And you'll be intubated, and what that allows you to do is to essentially a machine hijacks control of your breathing, and forces a high concentration of oxygen into your blood. It can into your lungs. It can also assist with taking out the carbon dioxide, which is another sort of important thing to build up to remove. But being in intensive care is a huge physiological stress. And it's also, patients are paralyzed, and so they're more prone to getting like clots in their legs and their lungs. There's all sorts of strange, when you get to that stage of things in this disease, there seem to be strange clotting disorders that start to accompany it, and people's kidneys by that stage are also taking a hit. So it's not uncommon for people to be on lots of anticoagulation blood thinners, and also many of our ITU patients are also on filters which are basically try and do the work of the kidneys for patients whose kidneys have stopped functioning properly. So these are the kinds of broad things that are happening in the hospital in terms of treatment for coronavirus.
There are some more questions in the chat box.
Yeah.
We have about 10 more minutes left to run. So maybe you can actually look at all of them and then give an overview, picking up on some of the points. Are there any other questions that people would like to ask verbally by just unmuting yourself for a minute? Maybe let's give Gabe all the last questions and then come back to us with a overview response. Any questions? Please do unmute or put in the chat box.
I've got a few that I'll start with, unless anyone's one of the things, where do we think we're going from here? Helen's asked. I think that that we are certainly seeing a dip, as I suggested before. Our ITU the coronavirus cases have shrunk in the ITU. There's the hospital. To be honest, the number of admissions for coronavirus is decreasing in our hospital. One of the interesting factors in all of this is that overall admissions are down everywhere across the country. People are just not coming to the hospital in the numbers that you would usually expect. And there's probably multi reasons for this. It may be that the lockdown itself has reduced the spread of other infectious diseases. It may be that people are thinking, I'll just let's see what happens with the stomach pain. Maybe it'll just go away. Could be that serious problem, people things like stroke are just, they're letting it go on for they're just not coming. And we are certainly seeing surgical patients attending late, and probably sicker than they would be otherwise, which is a problem. But yeah, I think I hope that the measures that the government's taken so far have worked to reduce the peak. I do think that as the lockdown eases, we'll see another peak, a second peak. Because I just think there's two ways of viewing this. Either you think this thing is so contagious that everyone in the country, lockdown or not, has already been infected, or not everyone, but many, many people, and the lockdown will have made no difference. I don't think that's likely, but it's possible that therefore when you open the lockdown, you're not gonna have much of a spike, because already everyone's had it or been exposed to it in sufficient numbers that we've achieved this herd immunity thing. I think that's unlikely. So I think what will happen, unfortunately, once we open the lockdown, is that you'll see cases starting to rise again as people communicate it to one another. But what will be different this time is that we will be better prepared. What was before a response, an emergency response, will be a plan. One of the things that a couple of people have asked us about, so what will strategy change next time? For example, about ventilators. Ventilation has kind of been a big issue here. The policy was predicated on the number of ventilators that we had, and certainly for the sickest patients, I think this is touching on Raphael's question. The sickest patients, we have to ventilate them. There comes a certain point where you are just not able to sustain gas exchange, and you're tiring, and at that point, if there's any benefit to be gained from ventilation, it will have to be done at that point. But things like I said, CPAP, seem to be for a certain group of patients, it seems to just push people back in the right direction. And I suspect that next time we won't be hearing so much about ventilator capacity, or maybe we still will, but we'll also be hearing about oxygen capacity at hospitals. And the reason you can't give CPAP to everyone is because these other non-invasive ventilation techniques are very high. They require actually a lot of oxygen flow. A lot of oxygen is wasted. If you've got a sealed system with a tube going into your lungs, actually it's quite efficient in terms of its use of gas. If you've got open systems, there's a lot more waste of the gas into the atmosphere around you. And the second related danger is about infection spread in this way. So it's not, even though it seems as a magic bullet, it is actually quite complicated to organize in a hospital-wide way. It's actually quite complicated. A system-wide way is quite complicated to get these other issues. I think that will be the next, personally, I think that will be the next touch point. In terms of ethnic groups, Fiona asked about ethnic groups affected. So yes, my hospital has quite a diverse ethnic population already. And so it's hard for us to say whether we are seeing it in the intensive care, a lot of people from Black and ethnic minority groups. Is it just reflective of our local population? I think it's something else is going on. And certainly there was a study done about healthcare workers, and it seems the number of Black and ethnic minority healthcare workers who've died does seem slightly out of proportion to their numbers in the NHS workforce. Is it, that's just what you've seen as a correlation. The cause, we could speculate for a long time, and I'm sure people will, about is it socioeconomic? Is it to do with comorbidities like hypertension or diabetes? Is it to do with lifestyle factors like diet? Is it sociological, like people live in, there's a mixture of young and old living in communities together, and so people are more likely to pass it to elder people, or there's more likely to be spread. Interestingly, it's not just BAME groups, it's also unfortunately our own community has seen a much higher than our rate of mortality. Jewish community has seen a higher than expected mortality rate. And I think that's especially true. I think that is especially true in areas, in more Haredi areas, to be honest. And so you can start to speculate again, why is it, another actually related point is sometimes the official government advice just fails to get through. And whether it's a linguistic problem or a technological problem, these are all, people will do PhDs on this, I'm sure, for a very, very long time. Okay, another question here is, yeah, I said we were part of a treatment. There's a lot being done. Yes, so thanks to Michael for asking about psychological and emotional impact. Yeah, so there's a huge amount of support now available. There's dedicated psychological support for doctors. We have a chill out room in the hospital. The lecture theatre has been turned in, there's no lectures going on, so it's been turned into a chill out zone with dolphins on the screen and nice calming videos of the ocean and sort of wafty music, and there's food in there and drinks and refreshments and so on. And we're encouraged to come in and not talk about the coronavirus, although that is largely what anyone is talking about. And yeah, so there's that at the local level, and then there's lots of psychological support. I'm not sure what the take-up, to be honest, I'm not sure what the take-up is like on this kind of stuff. People vent a lot to each other in WhatsApp group. I can tell you one spread is WhatsApp group. That WhatsApp groups has proliferated as a result in hospitals as a result of coronavirus. And there's a lot of kind of peer support going on, I would say, through these kinds of mechanisms as well. I should also say that it's not just doctors who've been affected. So lots of my wife Miranda is a speech and language therapist, and many of her colleagues have been reassigned into hospitals to either become ward clerks or donning and doffing buddies. That's the putting on and taking off the PPE to make sure that we do it properly, or to go train people in community settings to do that kind of stuff. Proning teams. I told you before about proning, this putting patients on their front. So you can imagine if a patient's conscious, it's one thing, but if they're unconscious, ventilated in intensive care, proning is a massive part of the day. It takes a team of 6 to 8 people. You've got to make sure that all their tubes and wires in the right place, that when you move them in such a way that their limbs are in the right place, that there's no creases under their clothes, that their masks, because they're lying sedated on their front at a sort of funny angle like this, with lines going in everywhere. So you imagine this is it's a big deal. So proning teams are a big part, and people are, in some centers, not ours, but some centers, the orthopedic doctors, the orthopedic surgeons have been have turned their skills into proners and deproners. The terminology is all evolving. No one calls it supiners, but there's proning and deproning, and so yeah. So people are being reassigned all over the place, and then I would say yeah, another couple of questions here. There's about why certain comorbidities are affecting people more. So, for example, why is high blood pressure and diabetes so prevalent? Well, first thing to note is that hypertension and diabetes are just prevalent in our population anyway. Having said that, they do seem to create a bit of an additional risk, and essentially no one has a clear answer. That's my takeaway from kind of trying to keep up to date with some of the relevant literature. Is it related to some of the drugs that people might be on? You know, the drugs that people are on is putting them at risk of coronavirus. That's one theory that's been put forward, and we've heard a bit about some anti-hypertension drugs. But actually, I think that some data that's come out on that now from China has suggested actually that's not the case. That people on their antihypertensives do just as well, if not better, than those with high blood pressure and not taking their regular medication. So please continue to take all your medications unless advised by a competent doctor. Yeah, so one thing I've seen, which I will just say, and has been borne out by the statistics, one obvious thing is that obesity is a risk factor for deterioration. And I think this is probably no more complicated than meaning that when you when you have more work of breathing to be done, you tire quicker, and it is just harder to oxygenate. If you've got more subcutaneous fat and a heavier chest wall, it's just harder for you to oxygenate yourself when you start tiring. And then let me just see if there's any final questions I can try and wrap up with. Yeah, so I do think Michael and Nicola have asked about whether this will have a knock-on effect on non-serious, non-coronavirus presentation. I think the answer is undoubtedly. In several ways. Firstly, some of the medications used for complex conditions are not known. We just don't know if they're safe to give in coronavirus. So, for example, many people who are on immunosuppressive medication for Crohn's disease or inflammatory bowel disease will have had conversations with their specialists about whether they can continue to take those immunomodulators if it puts them at a greater risk of coronavirus. And it may be that they will decide to continue taking them and shield. But for example, in hospital, we won't start people now. I was talking to our gastroenterologist. We won't start people on immunosuppressive medication for fear that they'll get coronavirus. So that's affected it. And then another thing, as I said, you don't want to offer procedures or surgeries where unnecessarily, which might cause a patient to become exposed to someone else with coronavirus. And so, for example, this has affected how we manage our heart attack service. So that's on the one side, that the services that we can offer. And then also definitely people are not coming to hospital. And if they, and I'm sure there are many people who, you'll see this, I think you're definitely going to see this in the excess mortality data, unfortunately. Yeah, people won't come to hospital, they will eventually come quite late. And as I said, we're seeing, yeah, you know, young people with burst appendices who've just sat on that pain for a bit too long, and instead of having their emergency appendectomy in a reasonable time frame, have come once all hell has broken loose, unfortunately. Ellie, any more, or do I have time for one or two more? What do you say?
One or two more, one and a half.
Testing and PPE. So PPE, yes, my hospital has access, adequate access. We are certainly in the intensive care unit, we are very well protected. I would say that there's a lot of consternation about the adequacy of the national guidance. So we can fit to the national guidance, but the national guidance currently says you should wear, if you're seeing patients with confirmed or suspected and not in a high risk for aerosol area, you should wear just essentially a simple pinny, you know, a plastic pinny, apron, and you should just make sure that once you finish it, you wash your hands and arms very thoroughly. And many of my colleagues are skeptical about that advice. I don't know if it's good, or I mean, I think it's hard to say. There's always going to be a trade-off between what you can supply basically and what your optimal medical guidance is. I think that's a truism rather than a scandal, personally. And then testing. So testing is complicated. Basically, if you have if you are symptomatic and you think you might have coronavirus, you should assume that you have coronavirus. If you get tested, either because you're sick enough to go into hospital or you've arranged a private test, and it says negative, do not assume that you do not have coronavirus. The negative predictive value of the test is not that good. So if you have symptoms, follow the government's advice. Even if you happen to have got hold of a test that says that you don't have symptoms and you think you can go out, I would advise you strongly to follow the 7-day at-home advice. If you're asymptomatic and you get a test, for example, healthcare workers, asymptomatic healthcare workers, so if they have a contact at home who's symptomatic, and you don't have symptoms, so you can go and get a test and you're negative, then in that context, it probably means that you do not have the virus, in which case you should, you know, it's in that context that we would come back to work. Once testing is being ramped up, one has to think quite carefully about how it's going to be used. Again, as I say, if you've got symptoms, you should stay at home. You should not use the test to think that you don't have the virus. On the other hand, if the testing is going to be used as a surveillance mechanism to see what number of asymptomatic people might still be carriers, might still be having the virus and infective to others, then that's another, that will be a very interesting use for it. And we don't know whether, so there's an antibody test, which is the testing whether your body is creating antibodies to the virus in the acute phase. So again, once you've had that, as I said, that's what I've been talking about so far. The second test is the antigen test, which is, sorry, other way around. To see whether you developed any. So the antigen test is what I'm talking about. The antibody test is to see whether you've got a sustained immune response to this virus. And that will be very useful to tell us how soon we'll come out of lockdown. Because if you do a very good survey and you can tell us that, you know, of your sampled survey, a big sample, it turns out that 5% of the population have had this disease, then I'm afraid we're going to be in for the long haul. Because if this is the chaos that we've seen with 5%, then we will, unfortunately, we'll probably have periods of lockdown and release going on for some time, and until an effective treatment is established, which may be quite soon, or a vaccine, which will change our risk profile, because even if people got it, then we can treat them, and then we'll say, okay, well, we don't mind if more people can get it because we can treat them effectively. If it's more like, if the antibody testing is showing us that actually something like 50% of people, or 20%, or an order of magnitude higher proportion have got it, then we're going to be celebrating, because it will mean that all the chaos that we've seen, and despite the very, it will tell us two things. It will tell us that if we open things up, or we won't have to be in lockdown for much longer, because already most people have got it, or a good proportion of people have got it, and so you know, so we don't have to be too worried about this in the future. And the second thing it will tell us is that lockdown hasn't done much good, because the virus is so contagious that despite the lockdown, everyone's still got it. And there's this kind of trade-off between the more people having it, the more people who have had it, in a way, reduces its lethality, because the more people who've had it, and this is the number of admissions and ill and death that we've seen, is then it's actually a proportion of a much higher number, and that's actually quite good news. So I think that's time up. Ellie, thank you very much. Thanks to all for tuning in. Sorry,
Dr. Gabe, thank you very much. Really informative. The comments are showing questions, but also huge compliments. So tremendous. Keep on going. And when we applaud the NHS on Thursday evenings, it's guys like you that we have in mind. We're certainly in good hands on the medical front with young doctors such as yourself on the front line. So thank you very, very much. And thank you to everyone.